Okay, so now we are moving forward for paracetamol. So today we will now discuss paracetamol, which is also known as acetaminophen. Now, we discussed earlier, I was discussing with all of you earlier that we have two types of names for each drug. One is the generic name that is given by the pharmacist, or after the research is that name is given to the drugs, that is like acetaminophen in this case. And paracetamol is the trade name, means by the name by which it is used in pharmaceutical factories, like they give certain names to the drugs and then it comes in the market. What is paracetamol? Actually, it is aniline derivative, and chemically we call it an acetyl P-aminophenol. It is the active metabolite of phenacetin. That's why we call it acetaminophen. Unlike aspirin, acetaminophen is primarily centrally acting, like it acts mainly in CNS. COX-3 is found in the brain and spinal cord, which is selectively inhibited by paracetamol. We discussed earlier that we have COX-1 inhibitors, we have COX-2 inhibitors, and we have COX-3 inhibitors. Among COX-3 inhibitors, we have paracetamol, and this paracetamol is selectively inhibiting COX-3, and where it is found mainly in brain and spinal cord. That's why we say that paracetamol is centrally inhibiting. It is selective inhibition of the enzyme COX-3 in the brain and spinal cord explains the effectiveness of paracetamol in relieving pain and reducing fever. However, we know that paracetamol is more effective than aspirin because it is more centrally acting. However, it has got no significant actions on COX-1 and COX-2, so lack of anti-inflammatory actions and GIT side effects as well. What are the pharmacological actions? It is an analgesic. It has got antipyretic effects that are similar to aspirin. However, it has no or very weak anti-inflammatory effect. It do not produce gastric irritation, erosion, or bleeding. It has got no effect on CVS, respiratory system, platelet aggregations, or coagulation, and as well no effect on uric acid excretion, so no effect on acid-base balance. Therapeutic use is one of the most important uses. It is used as an analgesic and antipyretic, particularly for patients in whom aspirin is contraindicated. And which patients they are contraindicated for aspirin? Having more prone to bleeding tendencies, in those patients, we contraindicate aspirin. What are the pharmacokinetics? Paracetamol is given orally. Peak plasma levels, they reach within 30 to 60 minutes. Plasma half-life is 1.5 to 2 hours. And peak protein binding, plasma protein binding, it is 25%. Mainly it is metabolized in the liver and excreted by kidneys in urine. Toxicity and common adverse effects. It is a well-tolerated drug, but more serious, or rather we can say it is an acute adverse effect when it occurs with overdosage of acetaminophen, and that is known as fatal hepatic necrosis. We discussed earlier that every drug is a poison until and unless it is administered in rational dose. At therapeutic doses, this is like we say 1.2 gram per day, it causes mild increase in hepatic enzymes. Doses above 4 gram may be very toxic, and 15 gram obviously will be fatal. It can kill the patient. Paracetamol is mainly metabolized in the liver into non-toxic products by glucuronidation, sulfation, and N-hydroxylation. This N-hydroxylation is 95%, and remaining 5% is metabolized by P450 cytochrome system of enzymes, and this is dependent conjugation forming toxic metabolite known as NAPQI, which is known as N-acetyl benzoquinoamine. Now, this toxic metabolite is very much toxic, and this can cause actually fatal hepatic necrosis. So we should be very conscious for administering the dose of paracetamol. This is actually showing how this toxic metabolite is formed. Here is paracetamol. It is, you see, metabolized by N-hydroxylation and rearrangement of cytochrome P mediated enzyme. And this is the metabolite that has been formed. This is toxic. This can cause toxic reactions with proteins and nucleic acids within the body. On the other way, we can see there's glucuronidation and sulfation, and there's GSH conjugation. Now, this GSH conjugation, actually, this is uh, antioxidant. We use it for the good effects. However, whenever this toxic metabolites are formed, this can overcome this. So then this conjugation will be hampered, or if it's not occur. How we manage the toxicity? Immediately we stop the drug. And this is the foremost thing for any type of a toxicity. Induce vomiting. Gastric lavage is washing of the GIT generally, but this is not recommended. Activated charcoal to further prevent absorption. Correct electrolytes, fluid and acid-base balance. Antidote is given that is known as N-acetylcysteine. This can deplete GSH stores and conjugate directly with the drug. This is the drug that we know, the toxic metabolite. This NAPQI is the toxic metabolite, and this serves as GSH substitute. So this stores, they are replaced by this antidote. This antidote can help to reverse the toxicity. Now, what are the COX-2 inhibitors? We have selective COX-2 inhibitors, Celecoxibs. And Celecoxib, Rofecoxib, this is the prototype. Celecoxib is a prototype drug, and these are the other drugs included in the group. Then we have preferential COX-2 inhibitors, meloxicam, nimesulide, and nebumetone. COX-2 expression means that where it is located. It is expressed, or it is mainly present in the brain, kidneys, female reproductive organs or a system, and bone, and induced by inflammatory cytokines in other tissues such as endothelial cells. COX-2 is not found in platelets, but it is present in endothelial cells, induces prostacyclin synthesis, and this prevents platelet aggregation and promotes vasodilatation. COX-2 inhibitors block endothelial prostacyclin synthesis, which leads to platelet aggregation and vasoconstriction. Definitely, whenever there is no prostacyclin synthesis, it will lead to, because prostacyclin breaks up the platelets aggregation, so that it doesn't allow the platelets to aggregate or to make a clot. So whenever it will not be there, so it will lead to platelet aggregation and vasoconstriction. Celecoxib is the prototype drug, and this is 10 to 20 times more selective for COX-2 than for COX-1. It is effective as other NSAIDs in the treatment of rheumatoid arthritis and osteoarthritis. It's a very new drug that is used these days for the treatment of rheumatoid arthritis and osteoarthritis. It causes fewer endoscopic ulcers, means GIT ulcers, or ulcers that are mainly within the stomach, mucosal lining of the stomach, than most other NSAIDs. It is a sulfonamide, so causes rashes. It does not affect, because sulfonamides actually they are very much popular for making the allergic reactions. So we will study these group of drugs later on, but just to here, I wanted to add that why it is specifically causing rashes, because they are very notorious for causing allergic reactions. It does not affect platelet aggregation at usual doses. It inhibits COX-2 mediated prostacyclin synthesis in vascular endothelium, so do not offer cardioprotective effects. So this is the table just showing the differences between aspirin and paracetamol. What is the source of aspirin? It is coming from willow bark and leaves. Paracetamol, however, it is semi-synthetic aniline derivative and active metabolite of phenacetin. Chemistry: acetyl salicylic acid for aspirin, and acetyl para-aminophenol is for paracetamol. Pharmacokinetics is also different, as you can see in the table form, that for aspirin it is mainly pH dependent. However, for paracetamol it is absorbed mainly from small intestine, and metabolism for paracetamol, it is hepatic, and as well for the aspirin it is hepatic. Metabolites mainly, now they are different. For aspirin, it is salicylate uric acid, lysine conjugates, and gentisic acid. However, metabolites, in case of paracetamol, it forms, as I told you, a toxic metabolite. and this can be buffered with reduced glutathione. Elimination, mainly first order kinetics with smaller doses and zero order kinetics with higher doses. Only first order kinetics with higher doses, this toxic metabolite can be formed, depleting glutathione stores and causes hepatotoxicity. Renal elimination is increased by alkalinization of urine in case of aspirin. However, no effect of alkalinization of urine on elimination in case of paracetamol. Mechanism of action, it is for aspirin that it is a non-selective, irreversible COX inhibitor, mainly at the periphery. However, in case of paracetamol, it acts centrally within the brain, CNS, and spinal cord, and it is selective COX II inhibitor. Pharmacological actions, aspirin is marked anti-inflammatory, analgesic, antipyretic, antiplatelet. However, paracetamol is very weak anti-inflammatory. Has got analgesic properties, it is antipyretic, but no antiplatelet effect. Uses almost the same, but aspirin has got a lot of uses. As you can see, it is analgesic, anti-inflammatory, antipyretic, uricosuric in very high doses. It is antiplatelet, PTA, patent ductus arteriosus, colon cancer, but we can use for prevention only. Familial polyposis coli, this is a disorder that it is associated with some bacteria. Barter's syndrome, niacin-induced flushing due to prostaglandin D2 and systemic mastocytosis. However, for paracetamol, mainly it is used as an analgesic, antipyretic, and in Reye's syndrome. You see, aspirin is causing Reye's syndrome. However, paracetamol is used for the treatment of Reye's syndrome. Aspirin, Reye's syndrome, if given as antipyretic during viral infections in children. However, paracetamol can be safely used in children. Aspirin can cause complications during pregnancy if given for a long period of time. However, paracetamol is safe during pregnancy. Then we have acetic acid derivatives. Acetic acid derivatives mainly include indomethacin, diclofenac, sulindac, dolmitin, and idotolac. Indomethacin is marked anti-inflammatory drug, and it is more potent COX inhibitor than aspirin. Patients' intolerance limits its use. Like patients usually, they are not tolerable to indomethacin, so not commonly used as analgesic or antipyretic unless fever is refractory to other agents, like if there's a Hodgkin disease. When tolerated, more effective than aspirin in relieving joint pain and ankylosing spondylitis and osteoarthritis. It is not uricosuric but effective in gout. This is approved drug for closure of patent ductus arteriosus. And this is the mechanism of action of NSAIDs. Again, just the summary, that arachidonic acid. This is just, I'm summarizing the same that we discussed in the first lecture. This arachidonic acid, whenever there's some trauma to the skin, accidental trauma, and due to infections, this can go to two pathways. This is just I'm just summarizing this mechanism in general. This arachidonic acid, it can go two pathways mainly. Formation of prostaglandins and thromboxans, and here only prostaglandins. Now here, what happens, in GI mucosa, prostaglandins are formed, and these platelets, they are formed due to thromboxan A2. This thromboxan A2 leads to hemostasis. Prostaglandins, they are used for GI mucosal protection. Here, prostaglandins, they are mediating pain, inflammation, and fever. Now, COX II NSAIDs, they can block this reaction. COX II inducible also block this reaction. And here, COX-1 constitutive, they can go through this pathway. Just this a summary of my first lecture. So I hope you all understand about the general mechanism of action of NSAIDs, and this flow chart, this schematic diagram is very important to know it. This is a very basic thing for all these drugs to understand their mechanisms, at which step they are acting. So I hope it was clear to all of you. And so thank you for your listening and attention.